Now we begin with the Neurology Symposium. To moderate the sessions, we have Dr. Rahul Yadav, DM Neonatology from Rainbow Children Hospital, Chennai. We also have Dr. KK Joshi, President IAP Kerala 2004 and National Executive Board Member 2017. He is a Senior Consultant at Prashanthi Hospital, Manjeri. We welcome you, sir, to the dais.
Speakers for the symposium are Professor Seetha Shankaran, Professor Ilon Shani, Professor Boris Kramer, and Dr. Agnetha Gauran. We humbly welcome you all to dais. Sorry, sir. Professor Boris Kramer could not join.
At the outset, I thank the organizers, especially Dr. Manoj and Dr. Vishnu Mohan, for giving us this opportunity to chair this session. This is a neurology symposium. The first talk is on hypothermia for HIA, evidence and unknowns. There is clear-cut evidence that hypothermia is very effective for preventing the complications of HIA. Professor Seetha Shankaran from USA, he's a speaker. She's a speaker. She's a professor of pediatrics, Wayne State University School of Medicine, Detroit, Michigan. Over to Professor Seetha Shankaran.
Good morning. I would like to thank the organizers of this really excellent, superb conference for inviting me. And the first thing I would like to say is that is a very old picture of mine that you showed. I have aged quite a bit after that. So thanks to Manoj and to Vishnu. I'm going to talk about hypothermia for hypoxic ischemic encephalopathy, focusing on what we do know based on evidence-based medicine, and then what we do not know as yet. I can move the slides, right? Okay. Oh, you want to?
Yeah.
Yeah, I'll just. Okay. Thank you.
You can move.
Okay. Thank you. So this is a slide of, where's the slide before this? Yes, this is a slide of hypothermia randomized controlled trials that were conducted in the high-income countries with the primary outcome of death or disability at 18 to 24 months of age. So here I have listed the CoolCap trial, the NICHD trial that I participated in, the TOBY trial, which was from the UK, the European trial, a trial from China, and the ICE trial from Australia. So what you can see here is that in each of the trials, there was a decrease in death or disability from the control group to the hypothermia group. And the significant decreases are noted in red. So the NICHD trial, there was a decrease from 62% to 44%. In the European trial, from 83 to 51, trial from China, 49 to 31, and the ICE trial, 66 to 51%. So it was significantly reduced. On the other hand, when we look at the cerebral palsy, again, some of the trials did find a decrease in CP at 18 to 24 months of age. Here you see that the TOBY trial, the rate of CP decreased from 41 to 28% in the cooled infants. In the European trial, 48 to 12. The trial from China, 28 to 14%. In our NICHD neonatal network trial, the rate went from 30% to 19%. That was not statistically significant. So I want to point out that the rate of death or disability has really decreased from the trials that I showed you that were published in the early 2005 onwards to what is currently known. So this is a slide where the first column is the cooled group of the first hypothermia trial that was conducted by the neonatal network. And the second column is infants cooled for 72 hours at 33.5 degrees Celsius in the optimizing cooling strategies trial that we conducted in 2017. So you can see that the rate of death or disability in the cooled infants has dropped from 44 to 29%. So this is very encouraging, but 29% is still high in the high-income countries. There was a decrease, whether it was moderate HIE or severe HIE. It was noted that mortality has really gone down in the high-income countries. In the neonatal network trial, it went from 24% to currently 9%. Then you see that infants with a normal MDI, mental developmental index, have gone up, and infants with a normal PDI, which is psychomotor developmental index, have also increased. Now, I will point out that at least in the neonatal network trial, the rate of cerebral palsy in the cooled infants remains unchanged. So that is the evidence for high-income countries with outcome in infancy. So the next question is, does neuroprotection persist to childhood in these trials? Here we have data that was published from the CoolCap trial, where the disability status at 18 months of age was strongly associated with ratings on a questionnaire, although only 46% of the surviving children were assessed. This is data from the NICHD neonatal network trial that we published in 2014. We had 97 survivors from the hypothermia group, 93 from the control group. We had excellent follow-up at 6 or 7 years of age. And you can see that the rate of death or IQ less than 70 dropped from 62% to 47%. This was significant when it was unadjusted, but once we adjusted for degree of encephalopathy and center, the significance was no longer there. And lastly, the third trial, the TOBY trial, where the outcome was IQ equal to or greater than 85. There was some loss to follow-up of the infants, as you can see, 145 seen in hypothermia and 132 in control. But you do see that the outcome of IQ in the normal range has really increased and stays increased in the hypothermia group as compared to the control group. So neuroprotection seen with hypothermia in the high-income countries continues to childhood. So let's address the next question. Can greater neuroprotection be achieved with either longer cooling or deeper cooling or both? So we did this in a trial where we randomized infants. We had a total of 300 and odd infants, and we randomized them to be cooled for 72 hours compared to 120 hours. And we did not find any benefit with longer cooling. On the other hand, the mortality rate actually went up with the longer cooling from 13% with 72 hours to 19% to 120 hours. When we looked at usual cooling, which is 33.5 Celsius, compared to deeper cooling at 32 degrees Celsius, again, we did not find any benefit to deeper cooling compared to the standard depth of cooling. So what we know now is we should continue to maintain cooling when it's used for 72 hours at 33.5 degrees Celsius. So the next question is there any evidence of an early biomarker that correlates well with later outcomes? So here is data from MRI that was conducted in the neonatal period with outcome at 18 months of age. This is from the NICHD neonatal network data, where we scored the brain injury from 0 to 3. So the more severe brain injury, the higher the scores. And you can see that with increasing brain injury in the neonatal period, there was an excellent correlation with death or disability. With death, it reached significance. And among survivors, there was a good correlation between increasing brain injury in the neonatal period and outcome at 18 months. Now, we did look at the same data on the children at 6 to 7 years of age, and we divided the children into those who had a normal IQ compared to those who had, a low IQ less than 70. And you can see that the neonatal injury in any cerebral area was much higher in those children with a lower IQ. Same thing with the basal ganglia and thalamus, and also with the caudate nucleus. When we looked at the anterior and the posterior limb of the internal capsule, there was more injury in the infants, in the children who were disabled. Same thing with watershed injury, and also with what we call hemispheric, where the whole brain is infarcted. So what this shows is that neonatal brain injury correlates well with childhood outcome. The TOBY trial also has published their data on neonatal MRI. You can see the data here. The hypothermia group infants had a reduction in basal ganglia thalamic injury, white matter injury, and PLIC. And there was an excellent correlation between the area of injury in the neonatal period and outcome at 18 months of age. Better predictability in the cool group compared to the non-cool group. Now, the third trial that showed the relationship between neonatal MRI and outcome at 18 months of age was the ICE trial, where the infants who had hypothermia had reduced white matter injury, and the greatest predictive value for 2-year outcomes was actually the PLIC and the basal ganglia thalamic abnormalities. So here we have shown data from 3 trials where the MRI appears to be an excellent biomarker of outcome, and 1 trial where the MRI was a good predictor of childhood outcome. Let's move to another imaging technique, and that is MRS, magnetic resonance spectroscopy. And this is data from a study called the MARBLE study, which was conducted in the United States, and my center in Michigan also participated. And what we see here is there is a clear delineation between the infants with a normal outcome, which is in blue color, and those with a adverse outcome, which is in pink color. So the first column that you're looking at, and I don't know if this is a pointer, right? Okay, so the first box that you look at, you see that the absolute concentration of NAA is much higher in the normal infants compared to those with adverse outcome. The second box is the ratio of lactate NAA, and you can see there that the infants with a normal outcome have much lower concentrations of lactate. The third one is a ratio of NAA to choline, and the last one is NAA to creatinine. And you see the same thing, that there is a clear delineation between infants with a normal outcome and those with an adverse outcome. Now, there was also an examination between the absolute NAA concentration and the Bailey scores at 2 years of age. And here you see in the upper two panels are cognitive outcome and motor outcome, and in the lower panel is language outcome. And once again, infants who are disabled, which is in red dots, have a much lower concentration of the NAA scores. So what the authors found was, when they looked at all biomarkers, clinical assessment, MRI, diffusion MRI, and MRS, you can see that the best predictability actually was with the an NAA absolute value that was noted in the neonatal MRS. So I think this is kind of a marker that will be used in the future. So now I want to come to another study that was recently published, hypothermia for encephalopathy in LMIC, low and middle income countries, called the Helix trial, because the trial was conducted to see whether the findings of the high income countries were similar in the low income countries. The inclusion criteria for the trial was very similar to the NICHD trial criteria. Infants needed continued resuscitation at 5 minutes or had a 5-minute APGAR score less than 6. All of them had to have moderate to severe encephalopathy performed by a certified examination. And exclusion were absent heart rate, life-threatening anomalies, and inability to attend follow-up assessment. The sample size was very robust to detect a 30% risk ratio with 80% power and 5% significant level, allowing for 10% follow-up. The total was 408 infants were required to conduct the study or the trial. So let's go to the characteristics of the infants. So there were 202 randomized to hypothermia, 206 randomized to usual care, and all of the neonatal characteristics were similar between the two groups. You will note that 80% of the infants in both groups had moderate encephalopathy. Seizures at randomization was really high, 74 and 73% respectively. So this is within the first 6 hours of life. Outcomes at discharge were a bit concerning because the infants in the hypothermia group had higher levels of gastric bleeding, persistent hypotension, pulmonary hemorrhage, prolonged blood coagulation, and severe thrombocytopenia. And what was of concern was that death before discharge was higher in the hypothermia group, 36% compared to 24%. Now, here's the outcome at 18 to 22 months. The only significant difference was death up to 18 months of age, and this was higher in the hypothermia group, 42%, compared to the usual care group, which was 31%. All other outcomes, death or moderate or severe disability, which was the primary outcome, was similar in the two groups, and disability, severe disability among survivors, the rate of microcephaly, survival without disability, persistent seizure disorder was similar between the two groups, including neurosensory impairments. In a subset of infants in the trial, the MRS was conducted. And what you see here is that the absolute concentration of NAA actually was similar between the hypothermia group and the control group. And the lactate to NAA ratio was also similar between the two groups. So it did not appear that there was any neuroprotection. Now, there were quite a few differences between the Helix trial and the HIC randomized trials that I showed you earlier. Helix had more outborn infants than the original HIC trials. The birth weight was lower. There were fewer perinatal sentinel events and fewer emergency C-sections. There was a much higher rate of seizures within 6 hours of age, around 75% compared to 50%. One important thing was that the control group infants had less elevated temperature because it was built into the trial that if an infant in the control group had an elevated temperature, immediately that infant was treated and the temperature was brought down. This is important because, as you know, elevated temperature in both the adult trials for cardiac arrest and the pediatric trials for cardiac arrest, elevated temperature, if it is controlled, does not offer, has similar neuroprotection as hypothermia. Now, one thing was that the Helix did not assess fetal environment because there was lack of data on antenatal and intrapartum status. Conclusions of the Helix trial was that cooling therapy did not reduce death or disability or brain injury on MR, but increased mortality. So among the infants who participated in this trial, the brain injury possibly occurred in the perinatal period rather than in the intrapartum period, because as I showed you, there were fewer perinatal sentinel events and fewer and more early seizures. So the question is this due to partial prolonged hypoxia or acute hypoxia on chronic hypoxia? So this is being actively investigated in the Helix trial participants. Now, can certain groups of infants in the LMICs benefit from cooling? And we don't know that. And what I would encourage is those centers in the LMICs that cool infants, that they follow their infants and perform some developmental assessment early. Let's move on to what about hypothermia plus therapies? Well, we all heard the presentation at the Pediatric Academic Societies in Denver just last month, showing that the hypothermia plus EPO was not beneficial. This is the HEAL trial. So it was very clear evidence showing no lack of neuroprotection. Now, there are some other studies being investigated, and I know this will be discussed in detail, including the stem cells, melatonin, allopurinol. We do know from evidence-based data that xenon, magnesium sulfate, topiramate were not beneficial in lowering death or disability. I would suggest that future studies should be adequately powered because the rate of death or disability has gone down. And the gold standard irrespective of imaging studies, the gold standard should still be neurodevelopmental outcome in infancy. Let's move on now to the unknowns in therapeutic hypothermia. And there are many, such as the practice that is rampant on cooling for mild HIE, cooling preterm infants, few instances of reports of cooling postnatal collapse and severe surgical conditions. And then I want to touch briefly on use of sedatives and analgesics during hypothermia for HIE. Hypothermia for mild HIE is carried out very extensively in US, Europe, and UK. Registry data has also shown the Vaughan registry, the Toby registry, the Children's Hospital National Database in the United States. So over 1,000 babies with mild HIE have been cooled, and no outcome data has been presented from the majority of these reports. If you look at the few infants that were with mild HIE that were inadvertently included in the randomized controlled trials of the HIC, really there is no difference between the hypothermia and the control group. Of course, we have to keep in mind that the numbers are really very small, and this is data from 2 publications. So I think, and I wrote this editorial in Journal of Pediatrics, that a randomized controlled trial of hypothermia for mild HIE is needed urgently, that we should select infants at highest risk. We should define the criteria for the neurologic exam for mild HIE because it can be very subtle. We should use the current depth and duration of cooling. And because mild HIE has much more subtle effects on childhood outcome, we should evaluate cognitive and behavioral outcomes with robust measures at 5 years of age. So I do understand this will take a large trial and lots of money, but I know that there are at least 2 major centers that have applied for funding for this. I think it's important to do this trial because if cooling is safe and effective, then cooling can be offered. But if cooling is not safe and it's not effective, the treatment should be discontinued. How about preterm infants? We know that the American Academy of Pediatrics, suggested 35 weeks as the gestation for cooling, but there really wasn't much data. And if you look at the Toby and the Vaughan registry, there are a number of infants have been cooled, but without any outcome data. And there is a single center report of cooling preterm infants with HIE. So there is an ongoing trial of hypothermia for preterm HIE, which I think will give us some answers. This is being conducted in the NICHD Neonatal Research Network in the United States. We are carefully looking at safety, looking at hemorrhage and thrombosis, etc. And we are also evaluating efficacy at 18 months of age, looking at death or moderate or severe disability. The study is being done using Bayesian analysis with a sample size of 168 infants. The last unknown that I wanted to touch on is sedatives and analgesia. Preclinical data in the animal models has shown that hypothermia was effective only when the model was sedated. And we also know that in both pediatric and adult patients who are being cooled, you have to sedate them because they shiver very severely. But in the NICHD neonatal data, we went back and looked at the impact of sedation and analgesia and found that there was no difference, no benefit to outcome based on the infants who received the sedation and those who did not receive the sedation. We also know that infants who are cooled have accumulation of morphine, and parents, and this has been published, are very concerned with sedation use because they associated it with end-of-life care, and also they have concerns about addiction. So when I want to conclude by saying that updates in therapeutic hypothermia, what has been shown with evidence-based data is that hypothermia at 33.5 degrees Celsius for 72 hours is safe and effective for moderate and severe HIE in infancy and childhood in the high-income country trials. Early biomarker of outcome in infancy and childhood includes both magnetic resonance imaging and magnetic resonance spectroscopy. I would just caution the use of sedatives and analgesics in infants who are being cooled. And lastly, neither the safety nor the efficacy of hypothermia for HI was noted in the Helix trial. The question that we don't know is whether specific groups will benefit. In the following conditions, the safety and efficacy of hypothermia for HIE has not been demonstrated, and that is in postnatal collapse, severe surgical conditions, preterm infants, and infants with mild HIE. Thank you very much.
Thank you very much, madam. It was a great discussion. Actually, as far as cooling is concerned, everybody in this hall is having two questions in mind. Why? Why Western studies gave a lot of good outcomes? Why our Indian study did not show? So why this paradox? And second question is whether to cool. After this second trial, actually, the doubt is there in everybody's mind, whether to continue cooling in India or not. So why and whether, actually, quite interesting observation from you is the number of hyperthermic children. The number of hyperthermic neonates in control group was there more in Western and less in Indian scenario. So can you please elaborate on that? Because these two parts can be explained based on this hyperthermic individuals in control group. What was that? Means suppose we are cooling, half of them we are cooling, half of them we are not cooling. Control group, we had a lot of hyperthermic babies. So what was that?
So you have to remember, in the first trial that we did, we in the control infants, we were measuring temperature, but not as frequently as in the cooled infants, because the cooled infants, you're continuously measuring the temperature. And we did not realize that infants with brain injury and HIE have elevated temperatures. It was only at the end of the study, when we were doing data analysis, and we actually, when we sent the paper to the New England Journal, that the reviewers asked, why is there a slight increase in temperature in the control group? So we went back and looked at it, and we have two publications, one showing that elevated temperature in the control group is associated with a higher risk of death or disability at 18 months. And we followed the same children in the 6 to 7 year cohort, and again found that those who had elevated temperature in the control group compared to those who did not have elevated temperature in the control group, that the risk of brain injury was higher. So the question is, why is the temperature higher? So we don't think it's environmental. You know, although these children, some of them were cared for under warmers and some, but there is data that when the brain is injured, the temperature of the brain goes up, and that is with indirect spectroscopy that has been shown that the brain that's injured has an elevated temperature. So I think that's very, very important information. I would also point out that the early adult trials on cooling for cardiac arrest did show benefit of cooling. And then they noted that there were control group adults who had elevated temperature. So they have done very definitive large trials now showing that when you compare hypothermia with controlled normothermia, that the benefit of cooling is lost. So yeah, so that is, it's a very interesting question, and I would caution all of us in the nurseries that when you have a baby with HIE, make sure you monitor the baby much more frequently than say every 6 hours.
Thank you very much. Because we observed that brain and temperature are two-way journey. Brain affects temperature, temperature also affects brain. And as you pointed it out, like this means avoiding hyperthermia is actually equally beneficial than causing hypothermia, according to the cardiac analysis.
Yes.
Thank you very much, madam.
Thank you.
So is any question from audience? Please
Yes.
go ahead.
Thanks, Prof. Thanks for your excellent interaction. This is Dr. Ramarao from Vijayawada. My question to you is about this Helix trial. We know that the study have shown that the outcome wasn't that good, especially in babies who are cold. So what is your recommendation? Because there is a number of studies have shown that the cooling helps, especially in neurodevelopmental outcome. So what is your recommendation and what's your experience, Prof?
Can you just repeat that again? What is my?
Actually, sir, what is happening? The sound is coming too high. So can you keep the mic a little bit away?
Yes, that's why it's echoing in the room.
Hi, Prof. This is about Helix trial. Helix trial have shown that the outcome wasn't that good in cold babies. So, but a number of European studies and US and UK studies, in particular the TOBI studies, have shown that the outcome was good in cold babies. So, what is your recommendation and what's your experience, Prof?
So that's why we have looked at it looked for the reasons why Helix did not show neuroprotection, and that's why we looked at the differences between the population, between the infants in the Helix trial and the infants in the high-income trials, and I showed you that slide. So the infants in the Helix trial, the birth rate was a little bit lower, but the most important factors, I think, is that there were very early seizures as early as 2 hours of age in the infants in the Helix trial, which makes you wonder that, seizures normally occur between 12 and 24 hours of age in asphyxiated infants. So these are very early seizures. So then that raises the concern, were these infants hypoxic and ischemic during the perinatal period rather than the acute intrapartum period. And the second thing was that the rate of perinatal sentinel events, cord prolapse, uterine rupture, etc., was much lower in the Helix trial compared to all the HIC trials. So the HIC trials, I think, captured infants who had acute events that were so that you could reverse the effects of the secondary energy failure. And the question is, are the babies in the Helix trial already have already received the insult during the perinatal period? Because of the very early seizures and the fact that there were much fewer perinatal sentinel events. So we are really looking at if there are any genetic markers. So that data is being looked at.
Thanks, Prof.
Professor Dr. Pratap Chandra, I'm a neonatologist, Motherhood Hospital, Bangalore. I was one of the participants in the TOBI trial in the UK and CoolCap trial at the Liverpool, as well as Marble study at the Coventry. And we have been cooling babies since I've come back to India for the last 6 years. So our experience has nothing similar to what is being described in the Helix trial. So a couple of observations, please correct me if I'm wrong. The number of deaths that happen in the Helix trial in the cooled group, 80% of them are moderately encephalopathic. And 80% of so many babies dying in the moderate encephalopathy would actually tell me the kind of care that the babies received. That was number one observation. Secondly, too many gastric bleeds, and and which could probably mean that these babies had DICs and increased sepsis. Is this one of the things that skewed your data? And the third observation is none of these babies were transported to your centers, right? So we are one of the few centers. I don't even know other centers who are actively cooling during the transport. So how we do it is creating a lot of awareness in the peripheries and then giving us an early referral. We go and pick up those babies, and we will be putting our data out very soon. We have already actively cooled 70 babies, and our experience is none similar to the Helix trial. Kindly enlighten me on this.
So you have cooled 70 babies where?
At motherhood, no, we have cooled right now 110 babies. As a standard of care, and 70 babies were actively cooled during the transport.
Mm-hmm.
Because one of the things is with moderate to severe HIE, that the time the babies come to your unit, it is already in a very bad shape. Whether it is going to be very hypothermic or whether it is hyperthermic, and the sepsis rates are very, very high in India. So the primary care for these babies within the first hour of life is completely lost. So this is one of the reasons I was thinking Helix trial could have been better served if more awareness was created around the referral centers, and possibly if you could have used active cooling during the transport. That was my observation.
Yeah, I have to point out that when you have a randomized controlled trial and the randomization is done appropriately as it was, the maternal and neonatal characteristics have to be evaluated in both the groups. And they were very well balanced in the Helix trial. So what the authors, and I'm one of the authors of the Helix trial. So what we are saying is that this is there's a different group of infants. Is the intrauterine environment of different? Are the rates of malnutrition different? And this was discussed yesterday. The rate of sepsis was not high. Culture-proven sepsis. So culture-proven sepsis was similar to the HIC trials. For those who are cooling infants, I would encourage that you do neurodevelopmental follow-up and then assess the infants. Yes, it is likely that certain groups of infants may benefit, especially those that have a normal pregnancy and have a mother who has excellent care, perinatal care, and who have an acute perinatal sentinel event. Maybe those infants will benefit. I don't know that as yet. So thank you for your question.
Thank you, madam. Now we'll take the last question.
Hello,
last
sir.
question.
Sir, madam, concept of cooling appears great. Like we have seen that in adverse situations, many of the animals, they go in hibernation period and their metabolism slows down, and when the conditions become favorable, they come out and they behave normally. Likewise, if a newborn baby is coming out of utero and situations are adverse for him due to any reason, so cooling can be a natural phenomenon. It's a good idea, and it cannot be refused that cooling is not beneficial. It may take longer duration of time for studies. My point is that the cause of damage due to perinatal asphyxia is due to generation liberation of free radicals. तो क्या हमने ड्यूरिंग स्टडी फ्री रेडिकल्स के लेवल को मॉनिटर किया कि नहीं, कंट्रोल ग्रुप्स में और डिजीज में क्या उनके लेवल्स कैसे थे, इसको मॉनिटर अगर करें तो हमारे व्यूज चेंज हो सकते हैं। ऐसा हमने किया था क्या?
Thank you very much, sir. So the question was about whether to monitor free radical injury, free radicals in those groups. Like that was the question.
Can you say that again?
The question was free radical injury is the mechanism of HIE. So can you do a next study? Can we include free radical measurement in cooled and non-cooled babies?
So I missed that again. Can we do a study?
Oxygen free radicals.
Pardon?
Oxygen free radicals of oxygen.
Oh, well,
that was the question.
We have many young people here today. We have many young people here today who I would encourage to do research on that.
Thank you, madam. Thank you. Next one, next and last one. This is last. After that, we won't take any question.
Thank you. First of all, I'd like to thank Dr. Shankaran, one of our pioneers in the field of neonatal neurology, for giving this talk. Mine is really a comment and really a call to arms in view of the Helix study. As you all heard, the Helix study unequivocally recommended that infants in the low and middle income countries not be cooled. Although it is a well-run study, I kind of feel that it has been let down by this recommendation, to be honest.
As far as my humble request to our audience, please don't express your opinions.
Sure.
Please stick to the questions.
Yeah.
Specific question, because madam is one of the well-known authority in world. So please stick to your question.
I think it is important to have this discussion, and that's why I'm expressing this opinion, because if we say that we should not cool these babies, it has a huge implication. And if you look at the study infants, those were drastically different to the high-income infants that we look after. So I work in Adelaide, and I've worked in UK and Toronto and all these sort of high-income places, and we hardly see seizures in the first 4 hours of life. So these are materially different babies. And secondly, I can't think of any physiological reasons why cooling works in the high-income country and doesn't work in the low-income country, especially when sepsis is the same. I mean, we don't see RDS babies not giving surfactant or not responding to surfactant here as opposed to somewhere else. So I think this is something that the Neonatology Society in India should really take up, because it's got huge implications both for the families of infants who might benefit from this, and also for the government, because it's a huge cost burden involved as well for the long run. So it's really a call of arms to sort of further look into this rather than abandoning cooling altogether. Thank you.
Thank you. Thank you.
Thank you. Next one.
Thank you, ma'am.